Thanks everyone for coming. I'm Jonathan Sonis, and working with Ben White. We're at Mass General Hospital in Boston. And we're going to be talking to you today about ED patient experience, and specifically how you can apply systems engineering to improve it in your own EDs. So we'll jump right in. Three general areas that we're going to cover today. One, background of basically why we feel that ED patient experience really is important and matters and should be a priority, why we think that you should as well. Second is a basic sort of framework for systems improvement or systems engineering, and specifically how this relates to patient experience and how you can use these tools to improve patient experience in your own emergency department. And then lastly, 5 systems-based improvements using systems engineering tools that you could go back and do this afternoon in your own shops. So at the end of our lecture today, we hope that one, you'll be able to appreciate the clear link between high-quality patient experience and high-quality patient care. Second, better understand the drivers or causative factors leading to either good or bad ED patient experience. And third, recognize the clear synergy between systems engineering science and patient experience improvements and how you can use systems engineering science to make these. And then lastly, high-yield, low-hanging fruit kind of interventions based in using systems engineering or systems-based interventions to make improvements in your own emergency department. So first, just a disclaimer. Neither of us is suggesting that you should try to turn your emergency department into the Ritz-Carlton, right? At the end of the day, this is about doing the right thing for our patients and providing better care. And as we'll talk about a lot today, providing a good patient experience is really integral to providing the best care that we can to our patients. So why is it that in the past 10 years or so we start hearing so much more about patient experience in the emergency department? It's for several reasons. First, the data is there that providing a good patient experience and providing an environment where your providers and staff can do that for your patients is actually good for our patients medically. So the data is there for hypertension control, hemoglobin A1C, diabetes control, and other sort of quantitative medical outcomes that are actually improved when patients have better experiences. A large part of this is because of compliance. When our patients like us, they believe us, they trust us. So when we ask them to do things like take medication or follow up with a specialist or go to your PCP, they actually do it. And maybe less often talked about, but very important, is that when we provide an environment where our staff and providers are able to provide our patients with a good experience, they have a better experience. We have a better experience ourselves at work. And this is sort of cyclical that, and the data bears this out, that if you're making your patients happy, you're happier, which then allows you to make your patients happier, et cetera. And in a day where we're very appropriately really focusing a lot on provider burnout in emergency medicine, we know that providing a framework for good patient experience in our departments actually makes our providers less likely to experience that. Common sense that we see this in the data that a department or a provider who has kind of good patient experience scores, whatever that happens to mean in your shop, less likely to have complaints against them. And the extension of that is less likely to have malpractice episodes, right? So when something inevitably does go wrong, our patients are less likely to sue us if they like us, right? And a little bit now, but we anticipate more in the coming several years, if we want to get paid for the work that we're doing in full, the experience that our patients have, and this is all just patient-reported, will factor into that. And in large part, that's due to the EDPC, or ED Patient Experiences with Care survey, which for those of you who are familiar with HCAHPS on the inpatient side, this is very similar, modeled similarly for the ED. And this is through CMS and asks questions like, did you get care within 30 minutes of arriving? How often did doctors listen carefully to you? And I should mention there are sort of mirrored questions for nursing as well. How often did your doctors explain things in a way you could understand, treat you with courtesy and respect, help you to reduce your pain, and then the sort of ubiquitous likelihood to recommend question. Would you recommend this emergency department to your friends and family? the best information that we have is that this is going to go from sort of a theoretical entity to actually being rolled out across the country later this calendar year. And assuming that it follows the same rollout strategy that CMS used with HCAPS, we can expect that at some point within the first couple of years, there'll be a small either penalty or incentive to CMS reimbursement, to Medicare and Medicaid reimbursement, and then at some interval, that percentage will actually go up over the next several years. So we're convinced that for all of those reasons, and maybe more, that this is really a topic we should be focused on. We hope you are too. And so in that setting, we set out to figure out, okay, well, what should we focus on, right? What are the actual drivers? What do patients in the emergency department actually care about the most? And as we started looking through the literature, these are the themes that came up over and over. But we found that in 2016 and 2017, when we wanted to look at this in a more structured way, there hadn't really been a very recent systematic review looking at, okay, well, what are the most cited themes? What should we focus on? And so we set out to do that. And our results actually surprised us a little bit. So far and away, the most frequently cited factor driving ED patient experience was staff-patient communication. And we expected that wait time actually would be like numbers 1, 2, 3, and 4, but actually it was a distant second. And then rounding out that top 3 was staff empathy and compassion. Basically, how much do our patients think that we care about them, right? And so 2 out of those top 3 are really the communication, the how are we treating them, do they think we care type of factors. And interestingly, that Ritz-Carlton thing, the thread count of the sheets, do they have a pillow, what color are the walls, that kind of thing is like a distant 5th. So with that, let's talk about sort of how you can approach making some changes to improve this.
Great. Thanks, Jonathan. Wow, there's some feedback there. Hi, everyone. Again, thank you for coming. I'm going to stand over here because I kind of prefer this side. Before we move into the slides about systems engineering, sort of just a brief overview. Systems engineering is a really cool and very broad topic. Some people admittedly find it a little bit dry. I find it absolutely fascinating. But today's slides are just going to be sort of a brief touch on different systems engineering tools. And each one of these ideas could be an hour lecture in itself. But to the extent that you have questions, feel free to reach out to me after. I'm really happy to send you resources and try to help you through the process. In addition, we're applying these tools to patient experience. But as you're thinking through some of these tools, just remember that they can be used for all kinds of different things in your ED to help improve patient care and the overlap between patient care and patient experience. So perhaps the most well-known systems engineering tool and most sort of ubiquitously applied is the rapid change cycle. And I think with respect to the idea of a single systems engineering tool that you could use daily in trying to improve your ED, this is it. It's also known as the PDSA cycle, or the Plan, Do, Study, Act cycle, and it can be summarized in sort of 3 main steps. First is identifying the target system that you're thinking about trying to improve. The second is asking 3 questions, and they're quite basic, but they're incredibly important. And then the third is applying the cycle, and the fourth is then repeating it again and again. So with respect to patient experience itself, how do you identify the target system? So Jonathan mentioned a few of the overall themes that have become more and more important as we've studied this topic in the literature. But we had a little bit of trouble at MGH kind of coming up with a way to share this idea with all of the multidisciplinary folks that need to get involved in intervention planning. So we put together a logic model. And this is another systems engineering tool that is really cool. It takes a little bit of effort, but it's a really nice way to lay out a number of elements and factors in a way that's sort of readily interpretable. Obviously, huge amount of detail on this slide, but the short summary of what a logic model is that it gives you a sense for the context that underlie outcomes that you care about, and the way in which those contexts translate into the effects that you see on various outcomes. And so in that way, you can give yourself either a collection of early low-hanging fruit options to focus on, or think about the really important stuff that people really need to get behind. At least, in our experience, this has been really helpful getting people to say, wow, there's a whole lot of stuff. Why don't we think about this or that, or teamwork? and how we should focus on that. So for the next year, in the last 6 months, and for the next year, we're going to be really working on this idea of teaming at MGH, partly because of the idea that it really relates to a whole bunch of these different important factors. So the other way to think about the target systems in patient experience is one of my favorite equations, which is the equation for happiness. And it is that happiness equals reality minus expectation multiplied by perspective. So not surprisingly, as your expectations go up and reality doesn't meet them, your happiness decreases. As an example, just think about taking your family to Disney World and being really excited to get on the Small World ride and then seeing this, right? And that feeling is something that I think is at the root of patient experience, and how we can just tip that balance with a number of these different tools that we're going to talk about. So I would just ask you as a thought model to think through being a patient in your own ED. And what would you expect as a patient coming into your ED? Would you expect to be greeted kindly and to start your care quickly? To be told this is going to happen, this, it might take this much time, to have your pain managed, to be kept informed about weights, a clean and comfortable ED, very basic stuff, right? And these are the expectations that our patients come in with. And then if we don't meet them, the happiness quotient decreases. So with that sort of way of thinking about identifying target systems, the next step in the rapid cycle change is to think about these 3 questions. And just as a suggestion for those of you that have to work through large groups to get anything done in your EDs, just put these questions right up on the board when you're having your multidisciplinary meeting, because it allows the discussion to be focused on sort of moving forward as opposed to getting bogged down in some of the details that can really stymie progress. So the first one is, what are we trying to accomplish? Obviously, it's important that everybody gets on the same page with that. The second is, how will we know that change is an improvement? So this can be metrics all along the spectrum. It can even just be, a very basic qualitative metric, but obviously we like to move towards quantitative metrics as systems engineers, so that's also an option. And then, what change can we make that will result in an improvement? And the whole point of rapid cycle change is that is by next Tuesday. It's not in 6 months or a year. It's, what change can we make, and then evaluate that change, and then move forward with the next one. And what this allows for, and we've had some trouble with it at MGH, which is also known as the Titanic, and we joke about the 1811 effect, and that it's really hard to move the needle. But what it can allow for is a lack of sort of larger commitment to working on a problem, especially for busy people, but a sort of more focused, okay, I think I can help you make that change by next week, or something small, and then we'll just see how it goes. We'll pilot this or that intervention. And for example, when we talk about the signage later that Jonathan was deeply involved in, the topic started to become this massive discussion of signs and how we tie them to different topics and the frequently asked questions. And then when we just focused and said, let's just get sort of something up there, it made it sort of easier to get everybody on board. And then, again, as we talked about, you apply the PDSA cycle again and again. Does anybody have questions about that brief treatise on rapid cycle change before we move into the 5 examples? Okay, so these 5 examples are chosen partly because of their importance and partly because they help to sort of highlight the importance of systems engineering tools that you can apply to improve on these topics. The first, as Jonathan mentioned, is listed first because it is probably the most important and most effective way to improve patient experience, which is to improve communication. And that is sort of broadly defined, but what we know about improving communication quality and frequency is that it improves your perception of your provider's attitude, the provider quality, and the quality of healthcare on the whole. So that's kind of a large effect for spending some effort in terms of trying to improve communication. Interestingly, there is also literature to suggest that improving the efficiency and quality of your communication decreases the amount of extra time that your providers have to spend with patients. So there's some benefit to that too. And that paradoxical benefit is one of the ways in which systems engineering is really cool too, because you can get to a place where with synergy and with moving towards progress, that the amount of effort that is required actually decreases. So the sort of most relevant systems engineering tool for this topic is human systems engineering. We are very early in our understanding of how to change human behavior and how to affect human systems. But what's interesting is as people have studied other natural systems and complex adaptive systems, that we can get to a place where we have a better understanding of what parts of the rules of a system need to change and how to simply affect change in a system that can be sustainable. So just a few very simple things you can do in your ED tomorrow. You can ask your providers to address their patients by name. You can ask your providers to introduce themselves, and this seems basic, but it is amazing how many providers don't introduce themselves in these studies. Sitting down, there's a really cool study that most of you have probably heard of, that sitting down increases the patient's perception of how much time you spent with them by, like, I don't remember exactly, I think it was 30% or it's some massive number. And then consider scripting common events. Doctors hate scripting stuff because it feels like you're taking away their autonomy. But again, getting back to the efficiency piece, if you say the same thing every time, hi, my name's Dr. White, I'm the supervising doctor responsible for your care, it just, you don't have to think about that anymore, right? And that's what I say. And part of the reason I say that is because one of our QDM questions is, did you know who was responsible for your care, right? And so scripting can be really helpful. And then finally, models of communication can be helpful. We have gravitated towards I care, partly because the T in ADET, or the thank you, has just seemed a little bit weird to us. But the I care that we use is actually a little bit homegrown. We're happy to share this with you, but it's really basic stuff, right? Introduce yourself, reassure the patient, acknowledge whatever it is that is causing them suffering, and then review and reflect at the end of the visit. So before you step out, make sure that you and your patient are on the same page. It's not complicated. And then discussing expectations, again, getting back to the equation for happiness. This was what I focused most of my career on for 10 years, was the idea of lean systems engineering and reducing waiting times. And it was fascinating when we finished this systematic review that waiting times is not the most important, and there's literature to suggest that the perception of the waiting time is actually more important than the wait time itself. But this is one of my favorite charts, which I've had in slides since 2008. And what it suggests is no matter sort of how good you are at providing care, that your patient's satisfaction with their care in the ED just rapidly decreases. And how many of us have a 3 to 4 hour ED length of stay, right? So at that number, 20% of your patients are already less satisfied with their care. And again, this comes from when we called it patient satisfaction. We now call it patient experience. But I think this holds true. And in addition to that, wait times are bad for all these other reasons that we know about, right? Delayed care, increasing morbidity, and a whole host of other reasons that tie this topic to both improving patient care quality and patient experience. So how do we fix wait times? Well, demand capacity matching and lean methodologies are your two go-to tools for that, right? So if your servers, either your triage nurses or your doctors or your beds, are outstripped by the demand on them, you're going to develop a queue, and that's going to result in a wait. And if there's waste in your system, if there's areas where there's extra time that's being spent, and we all have that, lean methodologies can be a really cool way to focus on that waste and eliminate it. And especially given that most people dislike waste, it's a very helpful sort of way to get your department to a place where everybody feels like the system's working better. And getting back to the component of the overlap between patient experience and staff experience, we would all love it if, say, for example, CTs took half the time that they currently take. And there are ways to sort of think about that. We have a bunch of different experiences. I'm happy to share them with anybody after the session. So process mapping, posting turnaround times has been really successful for us in that if you can get to a place where your system is reliable enough that you have a cycle time that is somewhat reproducible, you can just post those turnaround times. And for us, we posted turnaround times that were a little longer than our actual turnaround times, kind of like the hostess in a restaurant, right? Who says, yeah, it's going to be 45 minutes, and then you get your table in a half an hour and everybody feels happy. Again, equation for happiness. And then the other thing that was really beneficial to us was to think about changing the perception of the weight. So increasing the amount of distractions that you have, charging stations for folks' iPhones, thinking about videos, providing content to patients, and a pretty robust frequently asked question area of our website that Jonathan worked on. This is probably the trickiest of the topics in patient experience in terms of how to move the needle in a way that's sustainable. But what's really interesting about it is that in addition to being present on most surveys, there's literature to suggest that increasing the amount of empathy and compassion that is perceived in your staff increases the compliance with recommendations of the staff, the perception of the healthcare quality, and also makes your staff morale improve. And again, getting to how we're trying to work on reducing burnout. This is worth investing some resources in. The systems engineering tool that is sort of utilized to change human behavior is called the science of behavioral change. It's this whole idea of nudging and putting things on the floor to get patients to go in a certain direction. Those puppy stickers that you guys saw. Did you guys see the puppy stickers on the floor yesterday? That's the science of behavioral change. The key is that in order for this to be sustainable, it has to be moving towards cultural change too. So coming from the top, from leadership, and then having ongoing training and feedback, and utilizing educational tools that can allow for sustained behavioral change. So with respect to empathy itself, one of the sort of leading academicians in the country, Helen Reese, is at MGH. She's a psychiatrist who's really into this idea of empathy. She has a fascinating YouTube TED Talk video. So if you guys are having trouble with empathy in your shops, just watching that video is incredibly sort of motivating and inspiring. But this is her model. You can also pay for this model through her Empathetics company, but you don't have to, because this is it. And you can just train folks to think about these things. And it's not, again, complicated. It's the idea of really making eye contact with your patients, which is facilitated by sitting down, for example, as is the posture and sometimes the sort of affect that your provider has can all be affected by a simple sort of intervention like putting chairs in the rooms in a place where a provider can sit. And then the idea of really hearing the patient and demonstrating to them that you're listening, incredibly important. So this is to say that there are models, there are ways that you can start to move towards the science of behavioral change and improve empathy among your staff. How much time?
What was the name of the TED Talk lady who did this?
So it's Helen Reese. Yeah. As Jonathan alluded to, very frequently when people start talking about improving patient experience, immediately we move towards improving the ED environment, right? The low-hanging fruit of making things a little cleaner, making things look nicer, embroidered pillows, that kind of stuff. But it is actually true that there is a sort of a fundamental level at which if your ED is not clean or does not appear to be well organized, patients assume that the health care provided in that ED is also poor. And so from that perspective, if you have issues with cleanliness and organization or patient comfort, not enough warm blankets or not any warm blankets, not enough pillows, these are easy ways to think about trying to move the needle for patient experience. I will say that with respect to cleanliness and organization, there's Lean has a really cool system for this called 5S, where you can get to a place where your supplies are organized in a way that they actually look nice. So we have procedure carts, for example, that just look clean and ready to take care of a patient. So it's small steps towards giving the patient a feeling of comfort with the care they're receiving, but it's really helpful. Noise has become a big issue recently, especially for us in our overcrowded ED, but with respect to the number of monitors and monitor requirements, et cetera, it's worth thinking about noise, especially during the night hours. And something like providing earplugs to patients can be a really low-cost but very effective intervention that demonstrates both caring and compassion and also helps them to rest and heal. So the other thing that we have found some success with, because one of our attendings is into art, is having just even a few nice paintings on the wall to make the ED seem a little bit less sterile. And then moving our distractions around so that patients are, say, facing the TV. And in addition to that, having, again, the charging stations for smartphones, that kind of thing. Because then that helps distract patients from the little bits of ED environment of care factors that are perhaps not ideal. And then lastly, these are the signage, the signs that we put up initially. Obviously, they have nice colors and they're attractive, and the picture here is to draw people's attention to the website that they can visit for a frequently asked question. And in a sort of brief collection of data, we found that almost 90% of patients thought that these signs were helpful. Super easy, low cost, nice way to sort of demonstrate that you care about patients.
Where do you post them?
All over. So
In the room or in the hallways?
So both. In the initial evaluation rooms, the signage is a little different. It highlights how much time you're expected to wait, et cetera. And then in our results waiting areas and in our hallways, the signage sort of gets at, if you need anything, feel free to contact this or that person. And then this sign is ubiquitous. Again, trying to get people to actually utilize the website, and that's a whole nother discussion. And then finally, the callback program. So this is sort of understandably high resource, but is perhaps the best use of dollars because it gives you such robust data about what you can do better. And in addition to that, most patients don't sort of feel like their visit ended as soon as they leave. They constantly sort of reflect on it, and did they like or not like this or that component. And when they're doing that, if they get a call from a caring, thoughtful, helpful person who's just checking in, it can make a huge difference in their perception of the care quality, their satisfaction. And there was one study that demonstrated a 20% increase in that likelihood to recommend question, which is, a really large effect size. We're hoping to study that too, because that seems quite robust. But the other thing is that in addition to getting feedback about the patient's experience, you can get feedback about their actual health care quality and correctness or incorrectness, and sort of ways that you might fix your system on a more robust level. And then we also use this to sort of give feedback to staff. So one of the questions is there anybody that stood out during your care? And when staff identify when patients identify a staff member and then that gets emailed to them, it's really good for staff morale. Personally, I know it feels nice that, after having what I thought was a good interaction with a patient, 3 days later I get an email that says, oh, so-and-so thought Dr. White did this. And that's a value to this that I don't think has been quantified, but is at least subjectively quite significant. So in terms of the systems engineering components to this, feedback loops are incredibly important for various types of systems engineering and managing variation. So this, again, could be a whole lecture, but we have significant variation in most of our medical centers, at least in ours. It's all over the map. And this allows us to sort of understand some of that variation and move towards improving it. And then finally, for those of you that use Epic, there's a sort of a collection of various functionalities, some coming out in 2018 for communicating with patients, but there's also off-the-shelf texting apps that you can get if you don't have the ability to have a physical person calling your patient. You can consider using a system like this to text your patient and then perhaps get some feedback that way, and also make that contact that helps the patient understand how much you really care about them and their follow-up. So in summary, there's an inexorable link between high-quality patient care and patient experience, or at least we believe that. It's possible to intervene on most of the causative factors using system science, and improving patient experience and environment improves staff experience and morale as well. Questions? Thank you guys for staying for the whole time.